It's my pleasure to introduce to you our next guest. Dr. Arif Khan is an associate professor of pediatric neurology from Mohammed bin Rashid University of Medicine and Health Sciences in Dubai. He is also director and consultant pediatric neurologist at Bush Hill Hospital and the CEO and the founder of Neuropedia Children's Neuroscience Center. Dr. Khan, the floor is yours, and I shall say I'm really pleased to meet you in person because I know about your work.
Good afternoon, everyone, and thank you, Ms. Gino, for that fabulous start to the Rett syndrome session today. Imagine a girl who has a diagnosis of autism, cerebral palsy, Parkinsonism, anxiety disorders, epilepsy, and the condition is progressive, all in one. And that's Rett syndrome for you. And there are a lot of unique things about Rett syndrome, and we will try and discuss that in the next 20 minutes. So let me just start off with a little bit of history. 1966, this gentleman here, Dr. Andreas Rett, he was an Austrian pediatrician, psychiatrist, neuropsychiatrist, neurodevelopmental pediatrician, whatever you may call him, but he characterized about 8 to 10 girls and picked up the symptoms that he looked at them and said they have degeneration, they have developmental delay, autistic features, they have epilepsy, microcephaly, and he put them in a bracket and said this is probably a condition. But Rett syndrome was not called Rett syndrome at that point. It was just characterized. And he published his data in a German journal. It was not until 20 years later, in 1983, that this gentleman, Dr. Bengt Hagberg, he was a Swedish doctor, who wrote a paper describing 35 girls with very typical features, having developmental regression, autism, loss of purposeful hand movements, ataxia, and microcephaly. And he named it as Rett syndrome, obviously after Dr. Andreas Rett. And this was published in the Annals of Neurology and was read widely. So Rett syndrome became Rett syndrome in 1983. But at that point of time, no one knew how it happened. People knew that it was a genetic disorder. They knew it was X-linked because only females were having the condition. But they didn't know why and what gene is affected. Fast forward to 1990s. In 1992-93, Dr. Bird picked up that there is a gene called MECP2, but it was not until 1999 when Dr. Huda Zogby in Texas described how MECP2 leads to Rett syndrome. And she did a lot of work even after that on the functionality of MECP2 gene, how it produces the protein, and how an aberration, a mutation in the gene can lead to different phenotypes. And what we know of MECP2 gene, or the protein that it produces, is the fact that any aberration, what it does help is in remodeling the chromatin and its organization. And it is not a genetic condition, but rather an epigenetic condition, which is a chromatin disease in itself. I understand that we have many parents and non-medics among us, so I'll try and keep this as simple as possible so you go home with a slightly better understanding of the condition. So, my friend here, Ms. Gino has mentioned what Rett syndrome is as a definition, but I will just break it down a little bit more. So, in one sentence, it's a postnatal disruption of nervous system. It's an X-linked developmental disorder predominantly in females that classically presents as a stalling or stopping of developmental milestones, typically between 8 to 18 months after a period of normal development. And that's the key. You have a child who has early normal development, some up to 6 months, some up to a year, some up to 18 months, and then they start plateauing and then later regressing. But the 4 key features of Rett syndrome are progressive loss of purposeful hand skills, speech and language regression, gait abnormalities, and development of stereotype hand movements, also famously called as ringing movements. Some of them, or many of them, would have decelerated head growth, and in my clinic, for example, in neurology, I get patients referred to me for microcephaly when they are 4 or 5 years of age without a diagnosis. And it's one of the most commonest cause of intellectual disability in females. So among pediatricians, GPs here, if you have girls who are slowing down their progression, their development is coming down and their head looks small, think about Rett syndrome and refer them forward. So these are the core features, but they also have some comorbidities, some minor conditions like sleep disturbances, bruxism, which is grinding of teeth, autistic features, breathing abnormalities, autonomic dysfunction, seizures. They come to me a number of times just with epilepsy and then retrospectively get diagnosed with Rett syndrome. Inappropriate laughter. I get referred patients saying, oh, I think this child has gelastic seizures. But it turns out that it's not gelastic seizures, it's a behavioral laughter, and then the child has the phenotype of Rett syndrome. Diminished pain response. I remember seeing one child in the UK where the child couldn't feel pain. And the child put her foot on a burning charcoal, burnt her feet, but for some reason didn't scream out. And these kind of stories, we can pick up these symptoms and remember them next time in our clinical practice. So the simple explanation of Rett syndrome is that there is a mutation or an error in a gene called MECP2 that makes MECP2 protein. And this change or reduction in MECP2 protein, which plays a vital role in the brain and nerve cells. And it's not this protein itself, but what this protein does to the gene expression of other cells is important, because MECP2 helps other genes function. It's like a switch. The moment MECP2 is switched off, many other genes, but hundreds of different genes are switched off, and they cannot express themselves. And remember, with Rett syndrome, there is this unique thing about Goldilocks phenomena, that is, if you have reduced MECP2 in you, it will cause Rett syndrome, because there's loss of function. But on the other hand, if you have excessive amount of MECP2, it will also cause a condition called MECP2 duplication syndrome, which is even more severe in males. We will talk about that later. But remember, it is excess and deficiency both causing 2 different conditions. But it's almost always de novo, so it is not something that is inherited. You won't find parents having Rett syndrome when the child has it. To put it in simple words, it's usually sporadic or de novo. And if I look at all different genetic mutations in that gene, about 8 mutations make up about 65% of the disease. These are the most common ones. One gene, many phenotypes. Easy way to remember this is that you might have 900 different types of Rett syndrome, because there are 900 mutations in that gene that can cause Rett syndrome. And if I show you this picture here, this one, the one down there, you can see the number of genes that are lined up. All to your left cause severe symptoms, all to your right cause milder symptoms. I apologize to my genetic colleagues here. I'm trying to make it as simple as possible. But you might find a child with Rett syndrome who has all the 4 features, but it's fantastic. She's progressing, she's doing well, the regression is not as much. But on the other hand, you might have Rett syndrome with severe spasticity, dystonia, and the child is completely dependent on others and immobile. That's on the other end. So Rett syndrome it's like a spectrum, like autism, for example, where you have the severe side on one end and mild ones on the other. Let's look at some variants, and this is interesting. Males with MECP2. I have a number of times getting calls from GPs and pediatricians saying, this child has MECP2 mutation diagnosed in Germany or US. This child has Rett syndrome? No. MECP2 mutation doesn't mean Rett syndrome. And that's what we're going to just look at why. So there are 60 males with not Rett syndrome, but with MECP2 mutations that have been identified and reported, I say. were identified in the world. Now, when a male has MECP2 mutation, they can have 4 different presentations. Number 1, some are severely affected at birth. They have severe encephalopathy with seizures, and they die by the age they are 1 or 2. So very severe form. And probably because they don't have a compensatory X chromosome. Male have XY. So if your X is mutated, you don't have a compensatory chromosome. Number 2, some of them have clinical features like Rett syndrome. They might have features like a girl would have, but might be slightly lesser. Number 3, they do not fulfill the criteria, so they are called MECP2 related disorder. They have MECP2 mutation, boys. They might have a little bit of obsession, mild autistic features, maybe mild seizures, but not the features that you will see with Rett syndrome. They are bracketed under MECP2 related disorders. And the 4th is MECP2 duplication. Many boys are seen or diagnosed with MECP2 duplications. Remember I talked to you about excessive MECP2 protein. And these boys, they are probably as severely affected as Rett syndrome in girls. Minor variations, and one key feature is recurrent pulmonary infection in these kids. What happens if MECP2 duplication happens in girls? It's actually a milder form in them. They might have autistic spectrum, they might have some OCD symptoms, anxiety, and generally classified as a milder form of Rett syndrome. And you can imagine 6% of girls who show clinical features of Rett do not have the mutation. So a number of times kids are sent to me with all the 4 features of Rett syndrome. The hand movement, bringing, skills loss, some regression. But when you do a whole exome sequencing or genetic testing on them, they don't have a MECP2 mutation. But you can still classify them as Rett syndrome based on clinical criteria. What is interesting is 2 other genes. I won't go into the details of this, but we just talked about CDKL5 and we talked about FOXG1. We will talk about it. The CDKL5 mutation, the key feature is that the seizures start very early, within the first year. I have about 3 children with CDKL5 mutation, very young, diagnosed in the last 2 or 3 years, and almost all of them, actually all 3 of them, the seizures started in the first year of life. The FOXG1 mutation, they would also present with Rett-like features, but the key differentiating factor is structural brain changes. If you do an MRI on them, you would see absent corpus callosum, some brain changes that are very definite. But both of these conditions are very severe and with significant verbal disability. Let's look at the 4 stages of Rett syndrome. And I've tried to make it as simple as possible. So remember, this is not definite, this is a range. So a child with Rett syndrome, as Ms. Gino pointed out, would have complete normal development up to 1 year, 18 months of age. The stagnation age or stage starts between that 6 months to 18 months. They start developing postural delays and hypotonia. They're late in sitting, late in crawling. It might last for a few months, and then they go into regression phase, so downhill. Loss of acquired motor skills, communication, they have these movements coming out, seizures may occur at this age, breathing irregularities, and this regression phase might continue for a year, and that phase is very difficult. It's very depressing for parents because they can see their child deteriorating in front of them. And we as doctors, if you don't have a diagnosis, we'll be in a shock, we don't know how to help this family. Stage 3 is the pseudo-stationary phase or plateau period, where they start getting some of their skills back. They start recognizing their parents and strangers, they are more alert, the seizures continue though, there are breathing difficulties, gastrointestinal issues, and they start developing dyspraxia, incoordination of hand movements and function. And this stage can go on for 8 to 9 years. And I remember very well a family with a girl with Rett syndrome who came to me at 7 years of age when the child was in this stage of pseudo-stationary phase and said, "Are you sure your diagnosis was correct? Because my child is not progressing." And I said, it was a genetic diagnosis. I said, "I have no doubt, but I wish to God, believe in one, that I'm wrong." And then 3 years later, they went abroad, came back 3 years later, this child was wheelchair bound, quite spastic. So that will happen, but that stage came in late in that child's life. Stage 4, which is again further deterioration, but here there is motor difficulties. The child's gross motor function is affected, the movements are reduced, the child develops scoliosis and is wheelchair bound at that point of time. This can start anywhere from 10 years of age to up to 16, 17 years of age. most kids, almost all of them, they live for 20, 30, 40 years. So life expectancy is not reduced so much, but it's the quality of life that is affected in these kids when they grow up, and what support they have also matters. I'll spend some time on treatment. I've got 6 or 7 minutes. Yeah. So just a quick thing about treatment, because I think this is something that is so exciting. And yes, the condition Rett syndrome is very unique, but the treatment that's coming in this area is so exciting, at least to neurologists and geneticists. So I would like to share that with you. If you look after children with Rett syndrome, please make sure you read this article, which is Consensus Guidelines on Managing Rett Syndrome Across Lifespan. And this has been developed as a consensus statement using 22 different clinical sites by North American Rett Syndrome Clinical Network. What they've done, they divided Rett syndrome population into 5 categories. So up to 5 years, 5 to prepubescent age, prepubescent to 21 years of age, and adults. And they've given you clear guidelines what they should be screened for and what treatment modalities or conservative treatment modalities are available. The exciting bit, treatment, and I would be very cautious about saying reversal in this condition is coming. I'm sure you would have heard of this condition, this medication called trofinetide. Trofinetide has passed through its phase 1, phase 2, and phase 3 trial, and now on the 12th of March, there is an approval being awaited from FDA. And if FDA approves it, not years, but within months, there will be a treatment available. This is not cure, this is treatment available for Rett syndrome. What is it? It is a synthetic analog, a similar medication of insulin-like growth factor, a part of insulin-like, so what we call as IGF-1. There's a part to it which is called N-terminal tripeptide, and this is an analog of it, it mimics it. What it does is improves synapses and synaptic structures between neurons, and corrects the imbalances, and improves communication between neurons in the brain. And in animal models, it's for sure, it has reversed symptoms such as impaired memory, anxiety and hyperactivity, and compromised social behavior. The phase 3 trial, which includes humans, it has shown this improvement. In the next few months, if this comes out, we will see in natural population how this medication helps kids and even adults with Rett syndrome. The second company here, Anavex, they are working on a medication called blarcamesine, which is a sigma-1 receptor agonist and a muscarinic receptor modulator, expecting to help with similar symptoms, but this might take a little longer. But what's even more exciting is gene therapy, as usual. And let me just touch base on this. Why we are so optimistic about gene therapy is because of these 3 reasons. Number 1, it's a single gene. It's MECP2. We know the devil, the gene that is responsible. Number 2, we know in Rett syndrome, the cells don't die. It is not a degenerative condition. It is a progressive condition, but it is not a degenerative condition. I'm sure you would have heard of degeneration in human brains. If you take a biopsy of the brain in those kids or adults, you will see that the nerve cells have died. In Rett syndrome, they don't. They maintain their structure. It's just that their function is impaired. And number 3, now we know for a fact that if you boost MECP2 protein, you can reverse symptoms in animal models and hopefully in humans. This is one of the rare genetic conditions where even after decades of the child or individual going through the condition, you can reverse the condition, and that's what's exciting. So who's working on this? There's a company called Taysha, just to your right there, and which is working on this gene replacement therapy, but there are many others that are working on different mechanisms like RNA editing, MECP2 reactivation, and so forth. So Taysha is a company in Texas. Taysha means ally or friend, and they're working on a number of monogenic conditions, Rett being one of them. But the trial is being carried out in Canada. It will be expanded to US and UK, so the numbers are going to be higher. So the main aspect of this trial is that they're going to put in a MECP2 gene into that person's body, intrathecally, that means from the back into the CSF around the brain. And you can't just put a gene inside, so they're going to put the gene into a virus where the actual bad part of the virus has been taken out and the gene has been inserted, and they'll push this virus into the human body. And the good thing about viruses is they're very good in going and attaching to cells and depositing their material within the cell. And this virus will enter the human body, go to the relevant brain cells, and release this gene into pretty much all cells. These viruses are called vectors, or AAV9, and the study is called REVEAL. Currently, adults are only enrolled and recruitment is going on. And after this initial phase, they are going to include children and males as well. This is very exciting. And we are looking at the next 12 to 18 months, and we are going to have some good outcomes coming out of this, I'm sure. So in summary, Rett syndrome is a rare debilitating developmental condition primarily affecting girls, caused by MECP2. Please read that guideline. You can just openly access it on Google. The current management paradigms aim to control associated symptoms. We're doing that with seizure management, posture management, everything that we do as neurologists, as developmental pediatricians, as physiotherapists. And medications are under investigations, and that's why the road ahead for Rett syndrome looks optimistic.
Sophie currently is 19, but going back in time when she was about, when she was first born, she just seemed like the happy, sweet little baby that you expect to have, and she's still that sweet little, sweet girl, but at about 18 months we started noticing a decline in her skills. So, you know, she was, up until that point, she was getting skills, and then pretty soon it was like she was not progressing and reversing in some of her abilities.
Very typical, stereotypical movements. Dyspraxia. She can't eat with her mouth, so eating becomes difficult. She has bruxism, that's why she has a mouth guard, so she doesn't damage her teeth.
It is so important that we get the support for Rocky Mountain Rett Association so kids like Sophie can thrive and do the best that they possibly can.
And of course, Sophie needs the help of people around her, but even in UAE, there are a number of children with Rett syndrome who need our help. Thank you.
Thank you very much for an amazing presentation and also for all the support that got that great conversation. And I want to also thank Dr. Khan for explaining genetics in a very simple way. And it's true, Rett syndrome is defined by variable expressivity, and it's something else that different mutations in the same gene can have different impact into the clinical. So it's not always very simple to understand what is happening inside. But with passion and dedication, things can move on slightly. Thank you very much. Now there is a session for the families. There are allocated tables for different syndromes that we've been discussing today. So please. And thank you all for your attention and for your dedication and support for the rare disorders.